So I want you to imagine you're standing right in the center of a trauma bay.
Oh, wow. Yeah, that's a tense place to be.
Right. The fluorescent lights are just completely harsh. The room is totally packed with personnel. And a patient has just been wheeled in from like a really high-speed motor vehicle collision.
And time is moving entirely differently in that room.
Exactly. You literally have minutes, maybe even seconds, to make these massive decisions that will dictate if this person wakes up tomorrow, next year, or, never.
It's an incredible amount of pressure.
It really is. And today, we are pulling you directly into that incredibly high-stakes, highly time-critical world. We're doing a deep dive into acute, moderate, and severe traumatic brain injury management in adults.
And we really need to emphasize the sheer scale of this issue. It's not some rare thing.
No, not at all.
Yeah.
The data we're looking at is staggering. We're talking about 2.5 million emergency department visits, 282,000 hospitalizations, and like 56,000 deaths in the U.S. alone in just a single year.
Yeah, and the economic toll from that same data set is roughly $76.5 billion.
Billion. With a B. I mean, this is a massive everyday war being fought in intensive care units across the globe.
It really is. And for our deep dive today, our primary source material is this incredibly comprehensive clinical guide on adult TBI management.
Yeah, it maps out the whole process.
Right. We are going to trace this really harrowing chronological journey of a severe TBI patient from the exact moment of that devastating kinetic impact on the pavement, right through the ambulance, the ER, the operating room.
The grueling marathon of the ICU.
Exactly. And finally, into those highly unpredictable years of actual neurological recovery.
It's a heavy journey. But, before we get into the medical interventions, I was thinking about the anatomy of it all. Think of the human skull like a bank vault.
A bank vault, I like that.
Right. It's this evolutionary masterpiece, perfectly designed to keep the most valuable thing you own safe from the outside world. It's rigid, it's unyielding.
And normally that rigidity is exactly what keeps you alive.
Right. But what happens when the threat isn't outside anymore? What happens when the threat is locked inside the vault, expanding, and it just has nowhere to go?
Well, that's the Monroe-Kelly doctrine in action right there.
Break that down for us.
So you have this fixed volume inside the skull, right? It's made of brain tissue, cerebrospinal fluid, and blood.
The three main occupants of the vault.
Exactly. If you introduce a fourth component, like an expanding blood clot, or if the brain itself starts swelling, something has to give.
But the skull can't give.
Right. The skull won't yield. So one of those other components gets physically displaced. If not, the pressure inside that vault just skyrockets until it literally crushes the brainstem down through the base of the skull.
God, that's terrifying.
Yeah.
But before a trauma surgeon can even start fighting that pressure, they have to measure the damage from the outside, right?
Yeah, they need a universal language. And that's where the Glasgow Coma Scale, or the GCS, comes in.
The famous GCS.
Right. It's been the go-to for decades. It scores neurological function from 3 to 15. A 3 is deep coma, and a 15 is perfectly awake and alert.
And it's based on three things, right? Eye-opening verbal response and motor response.
Exactly. And each of those tests a different physical pathway in the brain. Like if you just open your eyes spontaneously, that's 4 points.
Meaning your brainstem is somewhat online.
Yes, the reticular activating system is working. If you can talk and you're oriented, that's 5 points for verbal, showing your higher cortex is working.
And the motor response is the big one, worth 6 points.
Right. If you can obey a specific command, it proves the pathways from your motor cortex all the way down to your nerves are intact. But when trauma hits, those scores just plummet.
So if I'm only opening my eyes because someone is pinching me, that's a 2.
Exactly. Or if you're just making garbled sounds, the verbal score drops to a 2. But the motor responses, those give us the most terrifying clues.
Like the posturing.
Yes. If a paramedic applies a painful stimulus, like a sternal rub, and the patient's body rigidly extends outward arms stiff, pointing down, that's a 2 on the motor scale.
That's called the posturing, right?
It is, and it's an incredibly ominous sign. It literally tells the doctor that the higher brain functions have been functionally severed from the brainstem. The lower centers are just firing uncontrollably.
Wow. So based on the total score, they classify the injury. Severe is anything under a 9. Moderate is 9 to 13, and mild is 14 to 15.
Well, and this is a massive shift in the field that number 13 used to be considered mild.
Yeah, I wanted to ask about that. The source material specifically calls out 13 as an unlucky number.
Yeah.
Why did the medical field have to suddenly shift what they consider moderate?
Because the data was horrifying. They did these massive retrospective analyses and realized that over 1/3 of patients walking into the ER with a GCS of 13 actually had potentially lethal bleeding inside their skull.
Wait, really? A third of them?
Yes. Actively expanding hematomas. So treating them as a routine mild case was essentially a lethal gamble. They were sending these people to observation and they would suddenly decompensate and die.
Oh, wow. So they had to adapt to the reality of the danger.
Exactly. Now, a 13 is firmly categorized as moderate TBI. It mandates urgent CT imaging and intense observation. The risk is just too high to ignore.
But the GCS has a pretty huge blind spot, doesn't it? Especially for the really severe cases.
Oh, a massive blind spot.
Yeah.
Because what's the first thing paramedics do for a patient with a GCS of 4?
Secure the airway. They put in a breathing tube.
Right, they intubate. But the second that tube goes through the vocal cords, you completely lose the verbal component of the GCS.
You literally can't talk.
Exactly. So the doctors just have to write down a 1 with a T for intubated. You lose 1/3 of your diagnostic data just like that.
Which is where the FER score comes in.
Yeah.
The full outline of unresponsiveness.
Yes, the FUR score was built specifically to solve this problem. It doesn't rely on speech at all.
So what does it test instead?
It looks at eye response, motor response, but then it adds brainstem reflexes and respiratory patterns.
So it's testing if the patient is breathing against the ventilator.
Exactly. Is the patient taking their own breaths, or are they breathing in these chaotic, erratic patterns that signal the brainstem is failing? It gives doctors a much higher resolution picture of the coma.
Okay, so the injury is scored. The clock has officially started. Now the focus shifts to the pre-hospital battlefield.
The side of the highway, the back of the ambulance.
Right, because the initial physical impact, the primary injury, is already done. You can't uncrush the neurons. But the source material focuses heavily on stopping the secondary brain injury.
Because the secondary injury is what actually kills most of these patients. The brain is uniquely vulnerable in those first 24 hours.
And the two major villains here are hypoxia and hypotension. Lack of oxygen and low blood pressure.
Right, and it all comes down to cerebral autoregulation. Normally, your brain tightly controls its own blood flow. If your body's blood pressure drops, the blood vessels in your brain open up wide to pull more blood in.
It's an autopilot system.
Exactly. But severe trauma shatters that autopilot. The blood vessels just become paralyzed.
Though they can't adjust at all.
None. Blood flow becomes entirely pressure passive. It's completely dependent on the blood pressure coming from the heart.
Which means if the patient has internal bleeding from, say, a crushed pelvis and their blood pressure drops,
the blood flow to their injured brain drops instantly, and those damaged neurons are suddenly starving for oxygen.
the numbers in the registry data are terrifying. It says the odds of death literally triple if a patient arrives with a systolic blood pressure below 90.
Triple, and even a slight dip below 100 doubles the mortality. The brain just cannot handle hypoperfusion.
So obviously you'd want to get a breathing tube in them immediately to pump oxygen, right? But the data on pre-hospital intubation is surprisingly conflicting.
It is incredibly controversial. The old dogma was always GCS under 9, intubate. But large observational studies found that when standard ground paramedic crews did it, the patients actually did worse.
Wait, how does securing the airway cause harm?
2 reasons. First, the drugs you use to paralyze and sedate the patient for the tube often cause blood pressure to bottom out. And we just
A drop in blood pressure triples the mortality. Oh, man.
Right. And second, once the tube is in, inexperienced crews often squeeze the manual breathing bag too fast. They hyperventilate the patient.
Giving them too much oxygen.
Actually, it's about blowing off too much carbon dioxide. Carbon dioxide normally keeps the blood vessels in the brain wide open. When you hyperventilate and blow off the CO2, the blood vessels violently clamp down.
So you're accidentally choking off the blood supply to the brain.
Exactly. You cause a massive secondary ischemic stroke. That's why aeromedical crews, the helicopter flight medics, get better outcomes.
Because they have more critical care experience.
Yeah. They use advanced monitors to ensure they don't hyperventilate, and they can juggle the blood pressure medications perfectly during intubation. For a standard ground crew, it's often safer to just use a basic oxygen mask and drive fast.
Drive fast and maybe give them TXA. Let's talk about the CRH-H3 trial, because this is a massive revolution.
Over 9,000 patients in this trial. It evaluated tranexamic acid, or TXA.
Which is a drug that stops the body from breaking down blood clots, right?
Exactly. It's an antifibrinolytic. Giving 1 gram of TXA within 3 hours of the injury reduced death in mild to moderate TBI patients significantly. It dropped from 7.5% to 5.8%.
I was thinking about this like a house fire. The physical impact of the car crash is the initial explosion.
Hmm.
But the hypoxia and hypotension, that's the fire spreading to the rest of the house, and TXA is like immediate fire retardant.
That's a brilliant analogy. It stops the hematoma from expanding and burning down the healthy tissue around it.
But the trial showed it didn't really help the severe cases, right? The GCS 3s and 4s.
Sadly, no. If the primary structural damage is already unsurvivable, stopping a secondary bleed with TXA won't change the outcome. The therapeutic window is really for those moderate injuries where you can still save the surrounding tissue.
Okay, so the patient has survived the transport, they're wheeled into the ER, and now the team has to finally peer inside the vault.
The diagnostic sprint begins.
They need a non-contrast CT scan immediately. They're looking for skull fractures, edema, hematomas, but while that's happening, the nurses are drawing blood and they discover something insane.
Trauma-induced coagulopathy.
Yes, the fact that the TBI itself causes the patient's blood to stop clotting. How does a brain injury thin your blood?
It's totally counterintuitive. You have this actively bleeding brain, but when the brain tissue is crushed, it releases massive amounts of tissue factor into the systemic bloodstream.
Like it leaks out of the injured brain.
Exactly. And that tissue factor acts like a spark. It triggers the body to form millions of tiny microscopic clots everywhere in the body.
Wait, so it causes clotting, not thinning.
It causes so much inappropriate clotting that it rapidly consumes all of the body's platelets and clotting factors. The tank goes completely empty.
Oh, so a consumptive coagulopathy. By the time the actual bleeding artery in the brain tries to form a clot, there's nothing left to build it with.
Exactly. The blood becomes dangerously thin, which makes the brain bleed even worse. The ER team has to rapidly pump in fresh frozen plasma and platelets just to replace what was burned up.
Man, the body really works against itself sometimes. And while they're fixing that, they also have to look for BCVI, blunt cerebrovascular injury.
The hidden killer.
This one is terrifying because of the latency period. The source explains that a skull fracture can stretch and tear the carotid arteries in the neck.
Right, the inner lining of the artery tears and a blood clot forms right there in the neck.
But it doesn't kill you immediately. It just sits there for hours or days until it breaks off, travels up to the brain, and causes a massive stroke.
Right, so the standard treatment to prevent that stroke is blood thinners.
Okay, let's unpack this. We have a patient actively bleeding inside their brain from trauma. And to prevent a stroke from this neck injury, the source says doctors have to give them aspirin.
Yes.
How do doctors balance giving blood thinners to a bleeding brain? That sounds like a nightmare.
It is the absolute definition of a medical tightrope. They use low-dose aspirin, just 81 milligrams. It stops the platelets from clumping on that torn artery in the neck.
But they avoid the heavy stuff.
Oh, absolutely. They strictly avoid systemic anticoagulants like IV heparin. Giving heparin to an acute TBI patient is universally prohibitive. It would turn a small brain bleed into a fatal hemorrhage instantly.
So they just have to accept a tiny bit of bleeding risk with the aspirin to stop a massive fatal stroke.
Exactly, provided the CT scans show the brain bleed is relatively stable.
But what if it's not stable? What if that CT scan shows a massive, expanding mass?
Then the tightrope walk is over. It's an immediate sprint to the neurosurgical operating room.
Time to actually open the vault. The source breaks down the specific thresholds for when they have to cut. Let's start with the epidural hematoma.
The classic neurosurgical emergency. On a CT scan, it looks like a lemon or a biconvex lens pushing hard against the brain.
And the clinical hallmark is that lucid interval.
Yes. The patient gets hit, gets knocked out briefly, and then wakes up totally fine. They're talking, acting normal. But under the skull, a torn artery is pumping blood at high pressure.
And because it's arterial pressure, it's literally stripping the tough dural membrane away from the skull.
Right. And eventually, the volume maxes out, the pressure spikes, and the brain herniates. They have to drill a hole and evacuate it urgently.
Then there's the subdural hematoma. That one is crescent-shaped on the scan, right?
Yes, it traces the curve of the brain. It's usually a venous bleed, so it's lower pressure. But it's uniquely destructive because the blood pools directly on the fragile brain tissue itself.
Causing massive swelling underneath. And the surgical metric here is very specific. They operate if the volume is over 50 cubic centimeters.
Or if the midline shift is greater than 5 millimeters, meaning the intense pressure has actually pushed the center structures of the brain more than 5 millimeters off axis.
It's literally shoving the brain to one side.
Exactly. And if the bleeding is deep inside the brain tissue, an intracerebral hemorrhage location is everything.
Especially if it's in the posterior fossa.
The posterior fossa is the base of the skull. It houses the brainstem. It is the most unforgiving real estate in the human body.
Because there's just zero extra room down there.
None. Even a tiny blood clot there will instantly compress the brainstem and block the flow of spinal fluid. It causes catastrophic fluid backup. Surgery is almost always immediate.
Okay, but what about penetrating injuries, like a gunshot wound? You'd think if someone has a bullet or bone fragments deep inside their brain, the surgeon's first job is to dig it all out, right?
You would think so. But the source says that aggressive deep debridement is actually highly counterproductive.
Wait, really? They just leave it in there?
Yes, because going deep into the brain to chase bullet fragments causes immense irreversible damage to healthy brain pathways that might have actually survived the initial blast.
Oh, so digging it out does more harm than good.
Exactly. And the data shows digging it out doesn't even prevent delayed infections. So the surgeon's real priority is just cleaning the surface and getting a watertight dural closure.
Sealing the dural membrane so spinal fluid doesn't leak out.
And more importantly, so outside bacteria can't get in and cause fatal meningitis. They seal the vault, give massive antibiotics, and leave the deep fragments alone.
Wow. Okay, so whether they evacuate a clot or seal a wound, leaving the OR isn't the end. It's really just the beginning of the marathon.
The true war begins in the intensive care unit, because surgery removes the clot, but the brain is furious.
Furious, traumatized, and swelling. This is where we get into the invisible war of intracranial pressure, or ICP.
This is the bread and butter of neurocritical care. The guidelines state that any severe TBI patient with an abnormal CT scan gets an invasive ICP monitor.
They actually drill a hole and put a sensor inside the brain.
Yes, either an intraparenchymal catheter, a tiny fiber optic wire right into the brain tissue, or an external ventricular drain, an EVD.
The EVD seems like the gold standard here.
It absolutely is, because it's not just a monitor. It's a therapeutic weapon. It goes deep into the ventricles where the spinal fluid is. If the pressure spikes, the nurse can literally turn a stopcock and drain fluid out of the skull into a bag.
Physically venting the volume to drop the pressure. And the absolute goal is to keep that ICP below 22 millimeters of mercury, right?
Right. Anything above 22 and mortality skyrockets. But staring just at the ICP is dangerous. You have to balance it with the cerebral perfusion pressure, or CPP.
Okay, time for some math. CPP equals mean arterial pressure, MAP minus ICP.
It's the mathematical representation of a brutal hemodynamic war.
MAP is the blood pressure pushing blood up into the brain, and ICP is the swollen pressure pushing back.
Exactly, and the difference between them is the actual force successfully pushing oxygen into the brain tissue. You want the CPP between 60 and 70.
But wait, if the pressure in the brain, the ICP, is too high and the blood pressure is too low, couldn't we just pump the patient full of vasopressors? Just force the blood pressure super high to blast blood into the brain?
It's a very logical thought, and historically doctors tried that, but it is disastrous.
Why?
Because, remember, autoregulation is broken. The blood vessels in the brain are paralyzed and wide open. If you crank the systemic blood pressure to 160 with drugs, you're blasting a fire hose into a broken plumbing system.
Oh, man.
The sheer force drives fluid right across the blood-brain barrier, making the swelling exponentially worse, and causes dozens of new microbleeds. You cannot outpump the swelling. You have to lower the ICP first.
So how do you lower it without just draining fluid? The source outlines a tiered management approach.
Tier 0 is the simplest. Elevate the head of the bed to 30 degrees. Let gravity help drain the venous blood out of the head.
And you have to keep their neck perfectly straight. Wait.
Absolute midline alignment. If the neck bends, it physically kinks the jugular veins, blood pools in the head, and pressure spikes.
Wow, just turning their head can kill them.
Literally. And if that doesn't work, they move to analgosedation, using deep pain control and sedation to manipulate the brain's hemodynamics.
Because even if they're in a coma, the physical irritation of the breathing tube causes pain spikes.
And pain causes sympathetic surges, heart rate spikes, blood pressure spikes, which drives up the brain pressure. So they use continuous fentanyl to blunt that pain reflex.
And if fentanyl isn't enough, they bring in propofol. The source says propofol actively decreases the cerebral metabolic demand. How does putting them to sleep lower the pressure?
Propofol forces the brain cells into a state of deep electrical silence. Because the neurons are essentially turned off, they don't need much oxygen.
Right.
The brain's blood vessels sense that drop in demand, and they constrict. That shrinks the overall volume of blood inside the skull, which rapidly drops the pressure.
That's incredible. But what happens when elevating the bed, draining the fluid, and propofol just aren't enough?
Then you transition to chemical warfare osmotic therapy.
This was fascinating. You're basically using chemistry to shrink the brain. The two drugs are mannitol and hypertonic saline.
Yes. Normal Favus saline is 0.9% salt. Hypertonic saline is massively concentrated, sometimes up to 23.4% salt.
It's literally osmosis. It's like putting salt on a slug.
Yeah, that's exactly what it's like.
You inject this super salty water into the bloodstream, and because it stays in the blood vessels, it acts like a chemical sponge. It literally pulls the excess fluid across the blood-brain barrier out of the swollen tissue.
The brain physically dehydrates and shrinks. It's incredibly effective. But the risks are massive. You have to push the patient's blood sodium levels up to 145, even 155.
Which is wildly abnormal.
Very. And the real danger is when you try to stop the therapy.
The rebound cerebral edema.
Yes. Over a few days, the brain cells adapt to the high salt by creating their own internal osmolase to pull water back in. If you stop the IV salt too fast...
The water floods violently back into the brain cells.
Exactly. Massive swelling, instant herniation. You have to wean them off it painstakingly slow.
Managing that requires so much data. And this is where we get into what I was calling the sci-fi tech, advanced neuromonitoring.
The technology in these ICUs is just mind-blowing.
Let's start with PbTO2, brain tissue oxygen tension.
Standard monitors just tell you if the lungs are getting oxygen into the blood. PbTO2 is a microscopic probe implanted directly into the brain tissue itself.
It tells you if the specific injured area is actually receiving that oxygen.
Exactly. You want it above 20 millimeters of mercury. If it drops below 15, you know the neurons are actively choking, regardless of what the systemic blood pressure says.
And then there's cerebral microdialysis. This one blew my mind.
It's incredible. It's a tiny catheter with a semi-permeable membrane. It continuously samples the actual extracellular fluid of the brain in real time.
So they are literally testing the chemical exhaust of the brain cells.
Yes. They are looking specifically at the ratio of lactate to pyruvate.
Right, because normally cells use oxygen and make pyruvate.
Mhm.
But if they are suffocating, they switch to anaerobic metabolism and produce toxic lactate.
Exactly. If that lactate to pyruvate ratio spikes above 25 or 40, it is a definitive biochemical alarm. It means the brain cells are actively drowning in acid and dying.
And the craziest part is, this alarm goes off hours before the pressure monitor or the CT scan shows anything wrong.
It lets them intervene before the structural damage happens. It also monitors glutamate. When cells die, they rupture and dump glutamate, which excites neighboring cells to death in a massive chain reaction.
A literal chemical wave of death. And they can just watch it happen on a screen.
It's unparalleled visibility. And the last piece of this tech is the PRX, the pressure reactivity index.
This is the one that calculates the optimal blood pressure, right?
Yeah, it uses intense computer algorithms to continuously plot the blood pressure against the brain pressure. It finds the exact mathematical sweet spot, the optimal CPP, where that specific patient's blood vessels are actually functioning properly.
So instead of guessing, the computer says, for this patient right now, keep the pressure exactly at 66.
Exactly. It's the absolute pinnacle of personalized medicine.
But sometimes, even with the salt, the drains, and the computers, the pressure just keeps rising. The patient enters the refractory phase.
The absolute worst-case scenario. The brain is actively trying to herniate. You have to deploy the weapons of last resort.
And the first one is the barbiturate coma.
We talked about propofol reducing metabolic demand. Pentobarbital takes it to the absolute extreme. It induces a total metabolic shutdown.
They use an EEG to watch the brain waves until it hits burst suppression, right? Just total electrical silence broken by tiny blips.
Yes. The brain requires almost zero oxygen in this state, so the blood vessels clamp down as tight as possible, desperately trying to lower the pressure.
But the collateral damage is awful.
It's catastrophic. Pentobarbital massively suppresses the heart. The blood pressure tanks, so you have to pump them full of adrenaline just to keep them alive. It paralyzes the lungs, leading to severe pneumonias.
It's like almost killing them to save them. What about induced hypothermia, freezing the brain?
They used to physically cool patients down to 32 degrees Celsius. For every degree you drop, the brain needs 6% less oxygen.
That sounds great in theory.
In theory, yes, it lowers the pressure beautifully. But massive clinical trials showed a tragic irony. It does not improve long-term survival or functional outcomes at all.
Why not?
Because cooling the whole body suppresses the immune system, leading to fatal sepsis. It stops blood from clotting, causing delayed brain bleeds. And the shivering forces them to use massive paralytics. The global consensus now is just to keep them at a strict normal temperature.
So if barbiturates fail, And hypothermia is abandoned. What's left?
The nuclear option, decompressive craniectomy.
They actually take the skull off.
They take the patient back to the OR, take a bone saw, and remove a massive segment of the skull. The guidelines say it has to be huge, at least 12 by 15 centimeters.
Basically half the head.
Yes, because if you just drill a small hole, the swollen brain will squeeze through it and shred itself on the sharp edges. You have to open the whole hemisphere and cut the dura to let the brain physically expand outward under the scalp.
Literally breaking the Monroe-Kelly doctrine. But this raises a massive ethical dilemma. The source talks about the Deccarai and Rescue Guide trials.
The Rescue X trial is heartbreaking to read. Taking the skull off undeniably saves lives. It dropped mortality from 49% down to 27%.
But what kind of life are they saving? The trials show that while fewer people die, way more people survive in a vegetative state or with severe disability.
It skyrocketed the vegetative survival rate from 2% to over 8%.
How do families even begin to make that choice?
It's the hardest conversation a doctor will ever have. You have to tell them, without surgery, they die today. With surgery, they live, but they might be permanently locked in or vegetative. The surgery fixes the pressure, but it can't uncrush the initial brain damage.
That is just gut-wrenching. And while all this is happening to the brain, the rest of the body is fighting its own war.
Systemic ICU care. You have to tune every organ perfectly.
Let's talk about the ventilator, specifically hyperventilation. The source says routine hyperventilation is now completely banned.
Yeah, for decades, the reflex was to crank up the breathing machine to blow off CO2.
Because low CO2 shrinks the blood vessels and drops the brain pressure. We talked about this in the ambulance section.
Right. It makes the numbers on the monitor look fantastic.
Right.
But it works entirely too well. The vessels constrict so hard that they completely choke off oxygen to the brain.
So they were actively inducing ischemic strokes to make the pressure number look good.
Yes. The microdialysis probes proved the brain tissue was starving, so now it is strictly banned. You only hyperventilate for a few minutes if the patient is actively herniating, just to buy time to get to surgery.
What about temperature and glucose?
A simple fever of 1 degree increases the brain's metabolic demand by 10%. It's like redlining a broken engine. So they give Tylenol around the clock and use cooling pads to lock the temperature at exactly 36.5 degrees.
And blood sugar. I read they used to try and keep it perfectly normal, like 80 to 1 in 10.
Tight glycemic control. But again, microdialysis proved that the injured brain needs more fuel. Forcing the sugar down to 80 was causing severe episodes of brain starvation.
So now they let it run a little high.
Yes, permissive targeting. Keep it between 140 and 180. Make sure the brain has the glucose it needs to survive.
And the oxygen relies on the blood, which brings up anemia. If a trauma patient has lost a lot of blood, when do you give them a transfusion?
It's a huge debate. Transfusing blood has risks: lung injury, fluid overload. So ICUs usually wait until the hemoglobin drops below 7.
But the TRAIN trials show that's bad for TBI patients, right?
Very bad. Waiting until 7 caused way more ischemic strokes and bad outcomes. The swollen brain just couldn't extract enough oxygen from that thin blood.
So they have to use a liberal strategy.
If the brain tissue oxygen monitor is reading low, they aggressively transfuse to keep hemoglobin above 9 or 10. You have to optimize the oxygen carrying capacity.
While doing all this, the doctors have to watch out for PSH, paroxysmal sympathetic hyperactivity.
An autonomic nightmare. About 10% of severe TBI patients get this.
The source explains it like a disconnection syndrome. The higher brain centers normally keep the fight or flight system in check, but the trauma severs those wires.
And suddenly, the lower brainstem just goes completely rogue.
Triggered by almost nothing.
A nurse turning them in bed or suctioning a tube, and suddenly, bam! Their heart rate spikes to 180, blood pressure shoots over 200, they sweat through their gowns, and their whole body locks into rigid posturing.
It's like a rolling physical panic attack while they're in a coma.
And it burns a massive amount of metabolic energy, which drives up the brain pressure all over again. They have to use a heavy cocktail of beta blockers and nerve medications just to suppress the storms.
So days turn into weeks, the swelling eventually stops, the EVD comes out, the drugs are weaned off, and we arrive at the absolute hardest phase for the family. Prognosis.
The ultimate question: when will they wake up?
Historically, doctors were incredibly pessimistic, right?
Very. Because if you look at a severe TBI patient at exactly 2 weeks out, only 12% are functionally independent. The vast majority are still vegetative or severely impaired.
So doctors used to say, at 2 weeks, that's it, it's permanent. But the TRACK TBI study completely rewrote that timeline.
It's an astonishing study. They followed these exact same patients for a full year. And at 12 months, 52% of them were functionally independent at home.
More than half.
Mm.
And the most insane stat, of the patients who were clinically diagnosed as vegetative at 2 weeks,
Over 3/4 of them regained consciousness within a year, and a quarter regained full cognitive orientation.
that utterly destroys the idea of a rapid, definitive prognosis. The brain operates on a timeline of months and years.
It does. But doctors still use prediction models like IMPACT to give families some statistical odds. And they use MRI scans to look for diffuse axonal injury, or DAI.
Okay, let's talk about DAI. That's when the shear force physically stretches and shears the white matter tracks, right?
Yes, the microwiring of the brain is torn apart.
So if an MRI shows that the wires are physically sheared apart, isn't that definitive proof the patient won't recover? I mean, a broken machine is broken.
It's totally intuitive, but it's completely wrong. The guidelines explicitly state that patients routinely have favorable outcomes despite having severe DAI on their MRI.
How is that even possible?
Neuroplasticity. The human brain isn't a static machine. It can physically sprout new connections and reroute entire neural networks to bypass the damaged areas.
So the MRI shows the damage, but it can't predict what the brain will rebuild.
Exactly. Which is why the guidelines say an MRI should never be used in isolation to make a terminal prognosis.
Which leads right into the most terrifying concept in this whole deep dive, the self-fulfilling prophecy.
It's the darkest shadow in neurocritical care. A patient comes in, looks terrible on the GCS, the computer model predicts a bad outcome, the MRI looks awful.
So the doctor, logically but prematurely, tells the family there's no hope.
They'll never wake up.
The exhausted family trusts the doctor, and they withdraw life support. The patient dies.
And the doctor marks it as a TBI death, proving their grim prediction was right.
But the patient didn't die from the brain injury. They died from the withdrawal of care. The pessimistic prognosis directly caused the mortality.
The lethal loop. It's why the guidelines are now so incredibly strict. You must wait at least 72 hours off all sedation, but preferably a full 14 days, before making any definitive calls. You have to give the brain time to clear the shock.
And if they're still vegetative after a month, the source mentions one last pharmacological trick, amantadine.
It's an old Parkinson's drug. But if you give it between 4 and 16 weeks post-injury, it significantly accelerates awakening.
Ow.
It blocks the toxic glutamate and massively floods the synapses with dopamine. It acts like a chemical jumpstart to the stalled arousal networks in the brainstem.
It's literally hitting the hard reset button on a frozen computer.
It really is.
Wow. Let's take a massive step back and just synthesize this unbelievable journey. We started with the sheer kinetic impact on the pavement.
The desperate race in the ambulance.
Right. And then the chaotic ballet in the ER, fighting coagulopathy, the brutal mechanics of the OR, sawing off half the skull, and then weeks in the ICU using deep comas and microscopic sensors to manipulate the actual cellular metabolism of the brain.
The biological resilience required to survive that gauntlet is nothing short of miraculous.
It really is. It's the ultimate testament to human biology and medical engineering.
But I want to leave you with one final provocative thought to mull over. We've spent this entire deep dive talking about manipulating the physical and chemical environment. Venting fluid, tweaking sodium, cutting bone. We treat the brain like a broken engine.
Right.
But look at that TRACH TBI data. Patients continue to show massive functional improvements between years 1 and 5 post-injury.
Long after the bone is replaced and the ICU is just a memory?
Exactly. So what if the true frontier of recovery isn't just in the ICU's osmotic therapy? What if it's in how our conscious experiences, our environments, and our social stimuli fundamentally physically rewire the microscopic architecture of the brain years later?
Oh, wow.
If a neural network can suddenly wake up a year later, driven by nothing more than the emotional weight of a familiar voice and intense physical therapy, what is the true hidden ceiling of human neuroplasticity?
That brings us right back to the bank vault. The paramedics, the surgeons, they deploy every weapon to save the structure of the vault. They stop the fire. But it's the profound, continuous human experiences lived inside that vault over the subsequent years that truly rebuild the treasure.